Okay.
Dr. Francois, what did you say is the cause of Pierre Robbins again?
First pharyngeal arc, I don't know if that's called it a malformation. Like,
Failure
yeah,
of
Yeah, it was
development.
just for a
Failure of
malformation,
development.
I
Failure of
think.
development of the first brain.
failure of development, yeah.
Of the first
First
pharyngeal.
pharyngeal arc, yeah.
Okay.
So, do you know how it separates from Tucha Collins? So, what did we say yesterday that separates our Tucha Collins from
The
Pierre
Pierre
Robin?
Robin.
So, what do we
So
look
we
at?
said that Chicha Collins also involves failure of development of the second arc.
Mm-hmm.
So in that case,
Mhm.
yeah, so in that case, you have everything that you have in Pierre Robin,
Mm-hmm.
but then in addition, there's usually hearing loss.
Mm-hmm.
And then the zygomatic bone also doesn't develop.
Yes. So those are the clinchers for Tucha Collins. You look at the peak, it's not developed. That's their face will now look abnormal. You know, that's that. So today we'll be continuing with the congenital penile anomalies. There are two types that we have to know: hypospadias and epispadias. I'm sure that in your exam you see one of these guys. It will just be, you know, a walkover for you guys to just pick it and move. Hypospadias and epispadias. In hypospadias, the problem there is that the opening of the urethra is located on the ventral surface of the penis. Why? Because the urogenital folds they are supposed to, fold over each other and close so that their opening can be at the tip here, do not close together. So even if they close, the close is not incomplete. So at the end of the day, the opening will be on the ventral aspect. Do you guys get that? That is the problem in hypospadias. The reverse is what happens in epispadias. In epispadias, the problem is that the genital tubercle is abnormally positioned. It's not positioned where it should be at the tip of the penis. So it's positioned at the dorsal aspect. That is why the opening of the urethra in epispadias is dorsal. So if this guy urinates, the urine will be moving up from the dorsal aspect of the penis. In hypospadias, it is moving up from the ventral aspect of the penis. And they have different pathophysiology. Hypospadias is due to the fact that the urogenital fold fails to fuse completely or incompletely. In epispadias, is due to abnormal positioning of the genital tubercle. And they have some associations. And anytime you see hypospadias, you want to rule out cryptochodism, that is undecided testes, as well as inguinal hernia. Inguinal hernia, which is indirect. Indirect now, because indirect occurs in young children. I hope you guys are aware of that in our GI knowledge. Hello, guys. Hello.
Yeah, with you.
Yeah, indirect hernia is commoner in young people. Direct hernia is the one that you see in elderly due to weakness of the transversalis fascia at the back. So that is why it comes from
Mhm.
the back to the front in direct. But in indirect, it's coming from the deep inguinal ring, to the inguinal canal. So that's the way it works. So the associations I share with hypospadias is indirect inguinal hernia, cryptochodism, and chody, that is a bending of the penis, either upwards or downwards. And you guys remember that your 5 alpha reductase is involved in development of our external genitalia by forming DHT. So someone that has 5 alpha reductase deficiency do not have production of the dihydrotestosterone. So nothing to associate to initiate the formation of the external genitalia. So the external genitalia formation problem can arise, and one of them is hypospadias. Because you remember all these things, folding of the urogenital folds to form our shaft of the penis, the penile urethra, is also under the influence of dihydrotestosterone. So hypospadias is common than epispadias, is very, very common than epispadias, and it's associated with three things: indirect inguinal hernia, cryptochodism, which is undetected testes. You can even find that testes within that inguinal canal. If you want to use that one to always remember it, because the testes can be hidden within the inguinal canal. So that's why if you are trying to palpate it, someone that has undetected testes, you might want to palpate along the inguinal canal up to the abdomen to find the level of the undescension. Then the Chody, which is downward or upward bending of the penis, is also achieved. Then epispadias, like I said, opening of the urethra is on the dorsal surface. And because it's a problem of the genital tubercle is an upward structure. So the bladder too is very close to that area. So it can be achieved with estrophy of the bladder. Estrophy of the bladder, EE. Estrophy of the bladder, epispadias, they occur, they go together. You want to rule out, once you see epispadias, you want to check for estrophy of the bladder because of their positioning. Okay. So yeah, so how does the testes and the ovaries, how do they descend? The quick way to summarize this pathway is just to know that there is the gubernaculum. Just picture the gubernaculum as a fibrous tissue that connects the gonads, the caudal end of the gonads, to the derivative of the um, inguinous scrotal swelling. So anything that forms the derivative of the inguinoscrotal swelling, am I saying the right thing? Yeah, the labioscrotal swelling, sorry. I knew I wasn't saying the right thing. So gubernaculum is a fibrous tissue that connects the end of the gonads to the labioscrotal swelling. And you guys know what the labioscrotal swelling forms. What does it form in the guy, in the male?
Scrotum.
Scrotum. While in the female, it forms what?
Labia majora.
Labia majora. So the gubernaculum creates a pathway for the scrotum, for the testes and the ovaries to descend. So it moves downward, from the gonad, then passes through the inguinal canal. It is actually the gubernaculum that allows, formation of that inguinal canal. So as it moves downward, it enters through the deep inguinal ring, then passes out through the superficial inguinal ring to the labia majora or the scrotum, depending on if the person is male or female. So I want to show us how the inguinal stuff looks like so that we can have a mental picture of what we are talking about. So let's look at the inguinal canal. So that descent of the gubernaculum and the testes or the ovaries is what actually creates that pathway. So it's coming from the abdomen like that, forming from the abdomen, the gonadal ridge here, then the gubernaculum connects them as descent like this on both sides, then downwards because this guy is a guy, that's why you're seeing the scrotum. So if it's a female, descend downwards into the labia majora. So now in the females, let's start with the females. In the females, the proximal aspect of the gubernaculum degenerates and forms the ovarian ligament. The proximal aspect of the gubernaculum in the females obliterate and form the ovarian ligament, while the distal aspect within the inguinal canal forms the round ligament of uterus. That is that. In the males, the proximal aspect of the gubernaculum degenerates completely and does not form anything, while the distal aspect of the gubernaculum in the males is called gubernaculum testis or scrotal ligament that connect the testes to the scrotum so that you don't have abnormal uncontrolled movement of the testes, because if the movement is abnormal, it can easily toss and testicular torsion can happen, and there could be ischemia and gangrene of the testes. So your scrotal ligament or your gubernaculum testis is a distal remnant of the gubernaculum that forms the scrotal ligament or the gubernaculum testis, which anchors the testis to the scrotum so that its movement is a little bit controlled. Now, what is the processus vaginalis? When the testes or the ovaries are actually descending downward from the abdomen to enter the deep inguinal ring so that they can enter the inguinal canal, a fold of peritoneum follows them. In fact, a fold of peritoneum is the one leading. It goes before them. Just like creating a carpet for their majesty. So it lines that inguinal canal before the testes and the ovaries now pass through. Now, before the testes rather passes through. So that once the testes passes through and descends into the scrotum, the peritoneum obliterates. But there's a part of the processus vaginalis that follows the testes into the scrotum. We call it the tunica vaginalis. Tunical, it invests, it surrounds, it covers part of the testes. We call it tunica vaginalis, just like a peritoneal covering of the testes. That's a tunica vaginalis, which is a continuation of the processus vaginalis from the inguinal canal. Now, what's the clinical correlate of this? Normally, you are supposed to have obliteration of the processus vaginalis. It will close so that you don't have anything passing through that inguinal canal again. But in some situation, it doesn't close. Even after within 1 year following birth, it's supposed to close. But sometimes it doesn't close, it remains patent. So when it remains patent, that means that that inguinal canal is opened. So abdominal viscera from the abdomen that is up can enter through the deep inguinal ring to the inguinal canal. Guys, what do we call that? When the intestine enters through the deep inguinal ring to the inguinal canal, what is that? Hello? Anybody? Is it that we don't have any idea? So that I will know. So that I will know it's my network or you guys just don't have idea. I want you guys to respond though, so that we can quickly move. Invagination of the intestine through the deep inguinal ring into the inguinal canal. What is that? Hello, are you guys still with me? Hello? Okay, you guys are talking. I can't hear you guys. I think my network is bad. I can't hear you guys at all. Oh my god.
The way you said, "Oh my god," is so funny.
Oh my, this my network is messing me up because I'm surprised. Are you guys
So,
not?
what network do you use? What network do you use? I'm really interested.
No,
What
I think
network?
I use MTN, but I think it's the area that I have. So I'm trying to get maybe a broadband or something so that we will stop.
Oh, okay. Can you hear us now?
But
I can hear you
because
guys now.
because me, I feel Airtel is always better, honestly. When I
Okay,
was using MTN too like that, I was always having that problem until
so
I
you
changed
guys
Well,
to
to
were
an
Airtel.
so you guys were
extent,
screaming. Oh my
they all
god.
have mood swings.
Okay, oh. So what did you guys now say now?
We said
It's an
indirect.
indirect
Yeah.
thinking,
Yes,
yeah.
because I'm
Indirect
like
signal, yeah.
like it's not possible for you guys not to know it now. So
When we
So,
tell teacher
Papa,
say
you
I
You've been
guys
don't
should
know what
screaming.
to
join.
call.
You guys should let me know so that we can move it. Oh shit, we know it, sir.
so so yeah, so indirect inguinal hernia can occur when there is persistent patent processus vaginalis. I'm surprised that USMLE failed to mention it here. At the same time, if intestine doesn't herniate through that patent processus vaginalis, fluid can also enter. So if fluid enters, you call it hydrocele. So the pathophysiology of indirect inguinal hernia and hydrocele are actually the same thing. It's just what enters that is different. So you are supposed to expect obliteration of that peritoneum in females. But in females too, it can persist and open. And we call it canal of Knock. You guys don't actually need it. But you guys should just know it for your academic stuff. Canal of Knock. And it can contain fluid. So if fluid is there, we call it canal of Knock cyst. Okay, so let's move down to, I hope you guys understand it. Do you have any question? So we don't have any.
No.
Okay. So the ovaries doesn't actually enter. The ovaries is just high up in the pelvis. They are high up in the pelvis. They don't get down to the scrotum or the labia majora rather. But it is a gubernaculum that enters through that inguinal canal to the labia majora. I will explain it when we get to the ligament of the uterus, so we understand very well there. So the gonadal drainage. So drainage of the gonads is very simple. We have the right and left, gonads, right and left ovary or right and left testes. So commonly, the common name is the gonadal vein. So we have the left gonadal vein and the right gonadal vein. The right gonadal vein, like you guys can see here, empties directly into the IVC, direct connection. I'm sure you'll have talked about this in renal system. The left one.
Yep.
So which one do you harvest? Which one do you harvest? For
The
those,
left kidney,
so
left
why
The
why
kidney.
do you
left,
harvest why do you
left,
harvest the left kidney?
because it's
Because it has
longer.
a longer
The
vein,
route is
Exactly.
longer.
So the
and then
left
it
the left
receives from
mhm,
the suprarenal and the left
exactly.
gonadal veins.
Fantastic. So the left gonadal vein empties directly into the left renal vein, which now takes it into the IVC. But you guys see that there's a more like a right angle connection here. So this is a form of anti-gravity stuff. So that means that it's possible for stasis to be happening here, and
Yeah.
the blood flow will be working extra to bring the blood up and now direct it, in this axis towards the IVC. So there's stasis here, so there's build up of blood in this area. So the pressure here is actually higher, than on the right side that is just direct connection. So there's no coughing, there's no bending, it enters directly. So this coughing or this bending disrupt the laminar flow. So there's turbulence and stasis and obstruction is likely to happen here, and the blood continues to pull downwards, towards this convolution of gonadal veins that we call the papilliform plexus. So when this papilliform plexus becomes distended, that's what we call the varicocele, right?
Varicocele, yes.
So varicocele is very bad for the testes because it increases the pooling of blood here. I know that blood is warm. Blood is warm, so it increases the temperature of the testes, which can easily damage the Sertoli cells. The Leydig cells are strong. They are resistant.
Okay.
So the level of testosterone
Okay.
doesn't actually fall, but Sertoli cell dysfunction can happen from a varicocele and also from an undescended testis. Because if a testis is undescended and is located high up in the
Abdominal
abdomen,
temperature.
the
Yeah.
temperature is not, because the reason why it's outside the body in the scrotum is to ensure that the place is cool so that it can work fine. But if it's within
Okay.
the body in the abdomen or something, it can get heated up and can lead to infertility, especially if it's bilateral. So that's that. For the lymphatic drainage, guys, you have to pay attention to this. You have to pay attention, especially this number one. Hmm? You can see it in your exam. Now, I will give you the way me I palmed it. You have to know that the gonads. So you have to have a mental picture of everything. That you have the paraiotic lymph node, the external iliac lymph node, the internal iliac lymph node, the superficial inguinal lymph node, and the deep. So you are moving from up to down, up to down. So the highest one is your paraiotic. The next one is the internal iliac, because that one is still superior compared to the internal iliac. So external iliac is superior to internal iliac. Then internal iliac offers internal deep. Then before you now get your superficial inguinal and your deep inguinal. So you are moving from up to down. So that means that all the structures that they will be draining will be from up to down. Now, the structure that are most superior are your gonads, the ovaries, the testes, as well as the fundus, that is the superior portion of the uterus. They are all at the same level. If you guys picture the uterus, you know that the fallopian tubes and the ovaries, they are the same level as the fundus of the uterus. You guys can picture that, right? Hmm?
Yeah.
Yeah, yeah. yeah.
So that means that the testes, the ovaries, and the fundus of the uterus, they are drained by the para-aortic lymph node. So guys, if they put lateral aortic, is it the same thing as para-aortic?
No.
It should be. Yeah, it
Yes,
should be.
yes, yes. It's the
It's
same.
not. It is.
Para is just by the side. So if you see
Have
lateral
you ever
aortic,
seen that? Have you ever seen that?
if you see I'm saying, I'm just, you guys already know what I'm saying. But if I'm talking like this, you know what I'm
Okay,
saying.
okay, 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 okay,
If you
okay, okay,
see
okay,
lateral
okay.
aortic,
Yeah.
that is what you should pick. Oh, lateral aortic. You know.
Okay.
I don't.
Now,
Sorry. So what
Okay.
are you saying? Are you saying para aortic is the same as lateral aortic?
exactly. Lateral aortic,
Okay.
para aortic, they are the same thing. So they drain
Yes.
the ovaries, the testes, and the fundus of
And
the
the fundus of the uterus.
uterus.
Okay.
Then you now go down. After the fundus, the next thing is the body of the uterus. Then the body and the cervix connected together. Cervix, the body, they are connected together. Then you now start looking at the bladder, superior aspect of the bladder, superior aspect of the bladder, external iliac, external iliac. Now let's
So
look.
what drains the one out, because one out drains the, okay, so ovaries, fallopian tube, superior fundus of the uterus. They're all at the same level. So all of them will be
Testis.
para-aortic, and testis.
Okay.
Okay.
Testes,
Okay.
your gonads. Now, let's leave this internal iliac for now. The way to learn the deep inguinal is the last. That's the deepest. That one is only for the glans. Your glans clitoris and your glans penis. Deep inguinal. Very straightforward. Once you see glans clitoris, glans penis, deep inguinal, that's what you should be looking for. Now, superficial inguinal is only for distal structures. You know that glans penis and clitoris too, they are distal structures, but you have separated them. But the other distal structures are for your superficial inguinal, like your distal anus, distal vagina, then the external genitalia, like scrotum, the vulva. The vulva, which includes what? The labia majora, the labia minora, the mons pubis, and all those things. So the vulva, distal vagina, distal anus, and the scrotum. Because the vulva equivalent of the males is scrotum. Males doesn't have vulva, but they have scrotum. So scrotum, vulva, distal vagina, distal anus, superficial inguinal.
Sorry, Dr. Barry.
Yes. Do you guys get it now? So I think the superficial inguinal and the
Yeah.
deep inguinal should be easy to learn. So the para-aortic is straightforward. That's just the gonad. So gonad para-aortic, gonad ovaries, testes, and the superficial, the fundus of the uterus, para-aortic. Then you go down. So after the fundus, what follows? You are looking at the body and the cervix of the uterus. Then you are looking at the superior aspect of the bladder, just in front of it. Superior aspect of the bladder. External iliac. External iliac is the one that follows the para-aortic. The aortic stuff will divide. Common iliac and the common iliac will now divide into external and internal iliac. So the next thing that follows your aortic is your external iliac. Then we now look at your internal iliac. Internal iliac is for the proximal structures and the continuation of the areas that are not drained by the external iliac. For example, we are talking about the superior aspect of the bladder. What will drain the inferior aspect of the bladder? That will be the internal iliac. Talk about proximal structures like the proximal aspect of the anal canal is the internal iliac. If you guys remember when we are doing GIT lecture, you guys remember that there's a diagram that they showed us that they were talking about innervation, blood supply, lymphatic drainage of the proximal anus, blood supply, innervation, lymphatic drainage of the distal anus. Do you guys remember when we were talking about hemorrhoids? You guys remember
Yes,
that
but
picture?
it's
Yeah. Yeah.
confusing. That thing has not stuck yet.
I know
Yeah.
that it can be confusing, but you
The
just
one that one is to the external iliac and the one is to the superficial inguinal.
yes. So the one that is up, that's your internal iliac. The one that is down is superficial
Okay.
inguinal. Distal
Inguinal.
The one
anus,
up. Okay.
distal
Say
inguinal,
it again, please.
distal anal, superficial inguinal, proximal anal, internal iliac, internal
So
iliac.
the one that is proximal means closer to the body. So the innermost.
I think I have lost you guys again. You guys I can hear you now. So I just had to calm
Okay.
down so that you guys can come back. Maybe when my network gets
Okay.
better. Okay, thank you, Dr. Lushola. So, Dr. Luatobi, you are saying something. Dr. Luatobi,
Is she
oh,
still there?
I think she has left too. Let's quickly move so that we can, we have a lot to cover. So,
Who else
in,
can hear us?
Dr. Francois, are you there, Dr. Zuliat?
I can hear you.
Okay.
I can
So,
hear you.
mhm. So we've talked about, the structure that are being drained by the superficial inguinal. Just think about your external genitalia and the distal structures. So external genitalia in females, vulva. External genitalia in male, scrotum. Except the prostate. Because prostate too is external genitalia, but prostate is internal iliac. Internal iliac. So scrotum, the vulva, then the distal anus, distal vagina. That's all about superficial inguinal. Then internal iliac is the one that drains the remaining part, all your proximal structure, proximal anal canal, proximal vagina, inferior aspect of the bladder, because superior aspect of the bladder is already taken care of by external iliac. So inferior aspect of the bladder is internal iliac. Then the prostate, cervix and the erectile tissue of the male, which is your corpus cavernosum, is coming from internal. Internal iliac is the one that is hardest to know. The other ones are easy. The other ones are easy. So you just start the gonads, ovaries, testes, and the superior aspect of the uterus, the fundus, paraiotic. We go down. Body of the uterus, the cervix, the body of the uterus, the cervix, then the um superior aspect of the bladder, external iliac. You leave internal iliac for now. We already know superficial inguinal is the one that is taking care of your distal structures. Distal anal canal, distal vagina, your external genitalia, talking about the scrotum in males and the vulva in females. Then deep inguinal is only the glans thing, glans clitoris, glans um, penis, deep inguinal. Then you now go back to internal iliac. So I already know that the superior aspect of the bladder is drained by the external iliac. So the inferior aspect of the bladder will be drained by internal iliac and some proximal structures. What are these proximal structures? Proximal vagina, proximal anal canal, then P, prostate. Then if you want to remember your corpus cavernosum, you remember it. So I think that's the easiest way you guys can, or what do you guys think?
Yeah, I think it's cool so far. I mean, so for me, right now, the ones that have stuck are the paraiotic. I can remember the gonads, so ovaries, testes, fundus of uterus.
Mm-hmm,
The right after that, I remember that. Okay, so the rest of the uterus, that's the body,
mm-hmm,
then the cervix.
mm-hmm,
Then, in addition to that, the upper part of the bladder, I remember
mm-hmm.
the external iliac.
Fantastic.
Then I'll go down to the deep inguinal and just remember that the glans clitoris and the glans penis.
No, no, no.
Then I'll
What did you say? Sorry, I didn't hear you
the
well.
deep, the deep inguinal lymph
Thank you.
nodes
Thank you. Thank you. All right.
will be drain the glans clitoris and the glans penis.
Okay.
Then we'll be left with the okay. So I didn't talk about the internal iliac. Let
Okay.
me come to the superficial inguinal. That drains more of the external genitalia, right?
Mm-hmm. Mm-hmm.
So I'll think of the vulva, the scrotum,
Mm-hmm.
distal vagina, distal anus.
Yes. Okay. Dr. Francis, are you still there? Okay, the internal iliac. Yeah. So I heard everything except the internal iliac.
Yeah, so that's the last one I was going to. So that's the one that sort of that one in my mind, I'm thinking of internal things, as Dr. Toby said. So
Mm-hmm.
I mean prostate, even though it's not really prostate, then you have the can anyone else hear me?
Okay. Yes. So Dr. Francis, I'm listening. So internal iliac.
Yeah. Yeah, so internal iliac, you have prostate,
Mm-hmm.
lower part of vagina of no, sorry, proximal part of vagina, but lower
Okay.
part of bladder.
Okay.
Yeah,
What about
then okay,
proximal?
then the last two I have to check. Pardon? Corpus
Okay.
cavernosum, yeah, and
Mm-hmm.
cervix.
There's another proximal thing that is not here, but I mentioned it. Proximal anus. So you have said distal vagina and distal anus for superficial inguinal. You say proximal vagina and proximal anus too for internal iliac. Do you get it? Hello? Hello? Dr. Francois. Okay, yeah. So I said, because you said distal vagina and distal anus for superficial inguinal, that means you must say proximal vagina and proximal anus too for internal iliac. Do you get it? Hello?
You know?
Yes, I can hear you now. I can hear you
So
now.
when I can hear you, I usually can you see the screen? I usually use the thumbs
Oh,
up sign.
okay, okay,
So
okay,
when I'm
nice.
pressing the thumbs up sign, you should know that we can hear you. Yeah,
All right. So you guys heard what I said about the proximal. So you said the
yeah we
proximal.
heard.
So that's just. I think you guys are good with that. Okay. So let me just move to the female reproductive anatomy. So this is the way the female reproductive tract looks like. You can see the fallopian tubes, the ovary, um, the body. This is the fundus of the uterus, the topmost part. This is the body. The narrow area, which is the level of constriction, is the isthmus. Then this small area here, the small passageway is the cervix, but it has two openings. The internal hose, which is this guy here, is the part that opens into the uterus, while the external hose is the part which is this one below here. The external hose is the one that opens into the vagina. So it has internal hose, external hose, and in between them, the cervical canal. Then, of course, you have the ligament. The ligament that holds all the pelvic structures together, connecting them to the pelvic wall and to other neighboring structures. Two ones are very important proximally. What are these two? The first one is the short ligament of the ovary. You guys can see here, connecting the ovary to the lateral wall of the uterus. Can you guys see? Hello?
Yeah, we can hear you. You said the what? The
So,
short ligaments of the ovary. I'm looking
yeah,
for it.
ovarian ligament that holds or tethers the ovaries to the uterine horn here. You guys can see. Then there's another one.
What's it labeled?
This is it. This is it here. Can you see my arrow?
Oh, it's not labeled. Okay.
No, it's not. Is it labeled? Okay, it's labeled here, but this one is not a good. It's labeled here. This is it here. It's connecting the ovaries to the uterine horn. This one is better. You can see this. Dr. Francois, can you see this? So I might not be you know what, guys? That thumb up of a thing might not happen because I'm not seeing the interface of the what's it called, the presentation. What I'm seeing is my unless maybe I minimize my. So if you guys answer me, it will be easy. Hello, are you guys there? Hello? Hello? Can you guys hear me?
But I know they're asking a couple of questions that they were like, so it was to have maybe the person has a cervical cancer, they want to do a surgery, which are usually structures will be disturbed. Somebody with PPH, which of the structures will be disturbed,
Mm-hmm.
like that. You get,
Mm-hmm. Majority of the time, it usually
yeah.
boils down to the ureter. Majority of the time, it usually boils down to the ureter because if someone is going for ovariectomy, you are going to clamp the ovarian, ligament so that you can identify. You are going to clamp the
Better part though.
infundibulo. Hmm? You are going to clamp the suspensory ligament of the ovary of the infundibulopelvic ligament so that you can identify the ovarian vessels and ligate them. So in the process of ligating the ovarian vessels, you might damage the ureter that is just at the back of it, which is this ureter here. Hmm? If someone is undergoing hysterectomy,
Mm-hmm.
if someone is undergoing hysterectomy and you want to, clamp the uterine vessels, you know that the uterine vessels enters at the level of the cervix here. So, and the ligament that is here is called the cardinal ligament that runs from the lateral wall of the cervix to the lateral pelvic wall. So, from the cervix to the lateral pelvic wall, that is the cardinal ligament, and it contains the uterine vessel. So, if you ligate uterine vessel, because the ureter also passes behind these uterine vessels, so they might get damaged too during the process of hysterectomy. Then, of course, we've talked about the ligament of ovary,
But so that is the infundibulopelvic ligament, right?
the one that is superior.
Okay, so both infundibulopelvic and cardinal ligaments will affect the ureter.
Yeah, exactly, exactly.
But
But
one is
So
oophorectomy,
but
one
the
is
ovarian
hysterectomy.
one is up. The ovarian one is up. The
mhm,
uterine one is down.
now
Okay,
that is it.
okay,
The
okay.
short ligament of ovary,
Okay, suspensory ligament of ovary. Okay, I
ovary.
get it. I think I'm getting it now.
So the ligament of ovary is connecting the ovaries to the uterine horn. Is the superior derivative of the gubernaculum. The the
Okay.
the inferior derivative of the gubernaculum is our round ligament. that runs from the uterine horn to the labia majora, because I said it that it connects the gonads to the labioscrotal derivative, which in the female
Which one are you talking about?
the round ligament, the round ligament. So
Round ligament. Okay.
so it connects the
Okay.
lateral, the
Okay.
uterine horn to the labia majora. So it connects the gonads, to the, what's it called, the labioscrotal swelling derivative, which in the female is um the labia majora. So then we've talked about the other ligament, the broad ligament. So let's just move. So the next thing we're talking about is that adnexal torsion. Adnexal torsion. So adnexal torsion is just a condition, is a surgical emergency, and it occurs when there is twisting of the ovaries. This ovary is twisting around the ovarian ligament that is here and the infidopelvic ligament that is here. So it's twisting around both of them. And one of the things that can cause that twisting is when you have an ovarian mass, either an ovarian cyst or ovarian tumor. If there is a cyst there or there's a tumor at that area, it can predispose to twisting around the axis of this ligament here, this ovarian ligament, or the suspensory ligament of the ovary. Now, once there's that twisting, you guys remember that the infidopelvic ligament contains the ovarian vessels. So it's going to shut off the lymphatic vessels that are there, as well as the veins that are there, because they have low pressure. So they are the ones that are going to, get shut off first. And you know that what the lymphatic does is to drain lymphatics from the ovary to the venous system. What the what's it called? What the venous circulation does is to drain used blood from the ovaries away, to the heart. So all those blood are not leaving the lymphatic fluid, as well as the venous blood are not leaving the ovaries. So they will be getting congested within the ovary. So the ovary gets, edematous, congested, and enlarged in the presence of continuous, arterial perforation. There's still continuous arterial supply, perfusion to the ovary. So the ovaries is still getting blood from the arteries, but it cannot drain blood away from itself. So it will continue getting bigger. So with time, it will get bigger, and the pressure within the ovaries will be too much, and it's going to exceed the arterial perfusion pressure. So it's going to cut off blood flow from the arteries, from the ovarian arteries to the ovaries. So eventually, there's going to be ischemia and necrosis of the ovaries due to that torsion, due to the fact that the arterial perfusion has been stopped. So of course, because of the fact that there's congestion, the veins are not able to drain it away, they can rupture, and it will lead to hemorrhage within the ovaries. So the classic presentation is that they will tell you in the question that this person is having a pelvic, or a flank pain. They will tell you the person is having a flank or a pelvic pain, and there's a mass in that region, and the person is vomiting. Once you see nausea, vomiting, a mass, an exam mass with pelvic pain by the side, maybe on the right or the left, you know that is ovarian torsion until otherwise proven. Ovarian torsion. And in surgical emergency, you must, lap that patient. Maybe you want to do a detorsion surgery or something, or you want to remove that ovary, depending on the state. If it's already necrotic, you have to remove it. So it's very easy to understand. Just know that there's twisting of the ovaries around the infidopelvic ligament and the ovarian ligament. So because of the twisting around the infidopelvic ligament, there is obstruction of the lymphatic and the vein. So they cannot drain blood away from the ovary. So blood will keep pooling within the ovary. So the ovaries will become enlarged and edematous. So with time, arterial perfusion pressure cannot surmount that edematous ovary, because it has its own pressure too. So at the end of the day, it's going to cut off the arterial perfusion. So it will lead to, necrosis, ischemia, and the ovarian vessels too, the ovarian veins too that are distended and dilated, they can rupture. So it will lead to hemorrhage. And all these things actually start if there's an ovarian mass, either from a cyst or from an ovarian tumor. And the classic presentation is, you know, pelvic pain, maybe left or right, mass within that area with nausea and vomiting. So once you see flank mass, adnexal mass, pelvic pain, nausea and vomiting, ovarian torsion, it comes out a lot. A lot. You can see it in the exam, and it will be very easy for you. So I've said it. You guys should pay attention to it too. It comes out. So then the pelvic prolapse. Pelvic organ prolapse is just when you have prolapse of your pelvic structures beyond or within the wall of the vagina. So what are these pelvic structures we are talking about? Anterior, central, and posterior. So if you look at the structures that are anterior, you look at structures like the bladder and the urethra. If you look at structures that are central, what is just directly behind the bladder is the uterus. Uterus, the cervix, and the vagina. Then if you look at structures that are behind the uterus, those are the posterior structures, like the rectum and the small intestine. So if you have prolapse of the bladder, into if the bladder can prolapse posteriorly into the vagina, we call that cystocele, and that's the commonest. That's an anterior compartment prolapse because bladder is an anterior structure. So if it now prolapse posteriorly into the vagina at the back, that is cystocele. So the way they will present is they will present with urinary frequency, urgency, and difficulty in urination. So you know that that's likely to be a bladder systole you are dealing with. Where you do your what's it called? All these what do we call all these? You do a speculum examination and you see that prolapse, you can confidently say that this is your systole. Then if it's a posterior compartment
Dr.
prolapse,
Babali, Dr.
yes,
Babali,
yes,
with the bladder one, you're saying that the bladder prolapses into what?
the vagina. You know that the vagina is just below
All right.
and
Okay.
posterior to the. I'm trying to show you what it looks like. The bladder will prolapse posteriorly into the vagina.
Bladder prolapse into vagina.
You
Okay.
know that the bladder is just in front of. See, look at it.
Yeah, so
So you can
that's
see
the
this bladder prolapsing posteriorly into the vagina. You can see it.
uterus.
Hmm?
Okay.
Can you see it, Dr.
Okay.
So
Yeah, I can see.
so it will cause difficulty in urinating, frequency, urgency, and all those. It can even affect the vagina itself. Sexual dysfunction.
Mm-hmm.
Sexual
Mm-hmm.
dysfunction.
That's true.
So now let's now picture that the rectum that is posterior is now prolapsing anteriorly into this vagina.
Okay.
So that's
Mm-hmm.
that's your rectocele. So they will be having straining, constipation, difficulty in passing stool because of that.
Yeah.
Then all the structures that are now central, that are between the bladder and the rectum, which includes, the bladder, the uterus, the cervix, and even the vaginal vault itself. Yeah, if someone had undergone hysterectomy, the only thing that is remaining is the vaginal vault. So you can have prolapse of this uterus like this into the vagina. Can you guys picture that the uterus is just entering into the vagina like that? Can you guys picture it? Or should I?
Yeah.
Or
No, but you said if the person has undergone hysterectomy, then there's no uterus.
no,
So
no,
it's
I'm
just
I'm I'm talking about that of the vaginal vault. Like if it's involving the vaginal vault, the vaginal
okay.
vault can also prolapse into the vagina itself. So the vaginal vault is just the upper part of the vagina that's remaining.
Oh, okay, okay, okay.
When someone has undergone hysterectomy. So the
Okay.
vaginal vault can prolapse, the cervix can prolapse, the uterus itself can prolapse into the you know vagina. And if you have prolapse of these three compartments, the anterior compartment, which is the bladder or the urethra, you can have prolapse of the uterus or the cervix or the vagina or the rectum or the small intestine. Three of them together, that's your procidential. So that's your uh uterine procidential. So that means a nation involving three compartments at once, a knitting like that. That's uterine procidential. Now, what causes or what predisposes to pelvic organ prolapse? Normally, what supports that, pelvic structures is your pelvic floor, your pelvic diaphragm. Now, when those muscles weaken, you are going to have, you know, all your pelvic structure descending downwards. They will descend downwards once your once the pelvic diaphragm becomes weakened. Now, what are the things that can cause weakening of the pelvic diaphragm? Multiparity. Too much childbearing can weaken those muscles. You carrying pregnancy for a long time, it weakens the pelvic muscles. So they can become weakened and the person can, have pelvic organ prolapse. Age. With age, they become weakened too. Obesity. All the muscles become replaced by fat. they become weakened. So don't forget these three things: multiparity, age, and obesity. They all weakens the pelvic floor, which could lead to development of a prolapse. Now, how will they present? Ideally, they'll present with pelvic pressure or bulging sensation from the vagina, as if something wants to move out from the vagina. Of course, there's a prolapse, so there'll be a tissue protruding outward from the vagina or a bulging sensation. And of course, pelvic pressure. Then, if it involves the bladder, there's going to be urinary frequency, urgency, difficulty in urinating. If it involves the rectum or the small intestine, constipation is the presentation. Of course, they all involve the vagina, so there will be sexual dysfunction. That one is constant. There's no way the person will have sexual intercourse because the vagina is already being distorted. So that is all about um, the pelvic organ prolapse. Then it's very important for us to familiarize ourselves with the histology of the epithelium. What are the epithelium histology? The vulva, the vagina, and the ectocervix, they are the same thing. The vulva, which is the outermost layer, the vagina, follows. Then the ectocervix is the part that is directly, posterior to the vagina. The three of them: stratified squamous epithelium, which is non-keratinizing. That's what you find there. That is why in these areas, what you commonly have is just squamous cell carcinoma is what you commonly have. Vagina squamous cell carcinoma, very common. Vulva squamous cell carcinoma, maybe from HPV, very common, very, very common. It's very rare for you to be seeing vaginal adenocarcinoma. So what can cause vaginal adenocarcinoma?
DES.
There is still
This
strabesтерol.
cholesterol.
Exactly. So use of DES. Thank you. So the next thing to know is the transformational zone. Transformational zone is just the zone between the ectocervix and the endocervix. So that is the zone between them. And that is the point of transition between the stratified squamous epithelium of the ectocervix and the simple columnar epithelium of the endocervix. So the endocervix, the uterus, and the fallopian tube, they are simple columnar epithelium. But that of the fallopian tube is ciliated so that you can have, movement of the egg, so that the egg can be, you know, propelled towards the uterus for implantation. That's why you have the cilia and the fallopian tube. So that can be dysfunctional in someone that has what condition? Anybody? Dysfunction of the cilia. We learned it in cardiology. Anybody?
Yeah.
This one,
Dining. What's it called?
Cartagena. Or what?
Catagena.
Cartagen.
Cartagena.
Catagena.
Yeah.
Okay.
Catagena. And it can lead to ectopic pregnancy because if you cannot have cilia to propel the fertilized egg towards the uterus, they will go and implant on that fallopian tube and it should lead to ectopic pregnancy. Cartagena
I
syndrome.
thought male.
Hello?
I thought it was just a male.
That the Cartagena B? No,
Yeah.
no. It affects both
Okay.
male and female.
All
So
right.
then you also have to pay attention to, you guys are going for exam. Cystic fibrosis can also cause male infertility. But the pathophysiology of cystic fibrosis causing male infertility is not cilia. It's due to absence of the doctor's difference. The doctor's difference is absent
Difference.
in males in cystic fibrosis. But in Cartagena,
Yes.
it is due to their ciliary dysfunction. So that is that. Then the last one is the ovaries. The ovaries are not simple columnar. They are
Dr. Babali?
yes.
Sorry, that Cartagena syndrome, is there any, I'm trying to remember, is there any particular protein that is involved?
Yes. Dynein.
Dynein or what?
I
Okay,
know.
okay.
Dynein. So if you so dynein, then when we get to biochemistry, we'll talk about the component of dynein itself. So dynein can be made up of, some structures that makes up dynein, like, axoneme, microtubules, and all those things. You learn it very well in your biochemistry because it's possible that that's what they will put in your exam. You just make the diagnosis of maybe Cartagena, cystic fibrosis or something, and what you'll be seeing will not be dynein. You're just asking you the molecular stuff.
Yeah.
So you guys have to pay attention to that area when we get to our biochemistry. It is very, 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 very important. So the ovaries is a secretory organ All secretory organs will be lined by cuboidal epithelium. Please don't forget. All secretory organs are lined by cuboidal epithelium. Our ovaries secrete hormones, estrogen, progesterone. So cuboidal epithelium, cuboidal epithelium. Vulva, vagina, and ectocervix are stratified squamous. Ectocervix, uterus, and fallopian tube, simple columnar, which is ciliated in fallopian tube. Ovary, simple cuboidal. Then uterus epithelium component changes depending on the phase. If it's in the proliferative phase, they are growing, so they will be long and tubular. But if it's in the secretory phase, that's the phase where they are secreting mucus, so the glands will be coiled. They will not be long, they will be coiled. The spiral arteries too will be coiled, and they will be very big. So once you are seeing coiled glands, secretory. When they are long and tubular, proliferative. Okay. So I think we are like, let me just talk about this one, then we'll start from trauma the next time. So we should have covered it because of the revision that we did. So this is just a pathway for ejaculation. This is all what you guys need to know. Don't worry yourself about this diagram. All what you need to know is just a pathway. How does sperm leave the testes? So from the seminiferous tubules where they are produced, immediately the next structure is the epididymis. Epididymis is directly connected to the vas deferens or the ductus deferens. From the ductus deferens, they empty into the ejaculatory duct. Ejaculatory duct is now the one that will now go and enter the prostatic duct, the prostatic urethra. It will empty into the prostatic urethra. Then, once it gets to the prostatic urethra, it's already in the urethra. Then to come out through the penis. That is it. Very easy. Very, very easy. So your seminal vesicles, your prostate, your bulbourethral gland, they will all empty into the urethra too. So that's weight contributing to the seminal fluid, so that you can call everything semen, because this is the pathway for sperm, not semen. Sperm, but semen will not join it. Seminal fluid will not join it at the level of the urethra from the seminal vesicle, from the prostate, and from the bulbourethral gland, so that they can mix together. They can provide nutritional support for the sperm, and everything is called semen. So I hope we get that. Very easy. Then this is a cross section of the penis. We have where you cut the penis. This is what you see when you cut the penis. So the first thing you see are the two erectile bodies. These two erectile structures is corpus cavernosa. So what's the lymphatic drainage for the corpus cavernosum?
The
Superficial
internal
gradient.
ileus.
So the internal hilia. Internal hilia. So the corpus cavernosum is the one that gets erected during the process of erection, so that the penis can stay rigid. It contains deep arteries. So these are the deep arteries of the penis that becomes perfused with blood, so that you can have erection because of rigidity of the corpus cavernosum. The corpus spongiosum is the one that surrounds the urethral part of the penis. This is the urethra. The erectile body that surrounds it is the corpus spongiosum. So for expulsion of semen to happen, your corpus spongiosum has to relax, so that your urethra can open and sperm can come out. Then immediately surrounding the erectile bodies here, okay, who remembers the embryonic structure that give rise to the erectile structures, which is the corpus cavernosum, corpus spongiosum? Where did they come from? We said it that day. Anybody?
Endoderm.
No, that's not what I'm asking. Yeah, it's endoderm, but that's not what I'm asking. Like, they have indifferent stage. So what's the indifferent structure?
Mm.
Are you talking about the urogenital side?
All
That's
those
not.
things, yeah. So
It's
which one? Okay.
genital tubercle.
Local.
The urogenital,
Genital
Ah,
tubercle.
the genital tubercle. The genital tubercle. Thank you.
mm,
That's good.
Yes,
Genital
genital
tubercle.
tobacco.
Genital tubercle. Give rise to the glans penis or the glans clitoris, as well as the erectile structures. What is the erectile structure in female?
The vestibular gland.
The vestibular
Vestibular
bulb. The
Vestibular
vestibular
bulb,
bulb.
rather.
The
bulb.
vestibular
Oh
bulb.
God.
Now,
It's okay.
what surrounds the God will forgive you. Me, I want to round up this
Oh
class.
my God.
I want to round up this class. So what's
Oh
around
my God. Oh.
the I don't they do revision like that now. Now revision be that. So what's around the erectile body?
Wait, you
So
called it the urogenital tubercle, Abi? Urogenital
I
tubercle,
didn't hear
Bam.
what the person was saying well, very well. That's why I said urogenital what? Apparently, the person was trying to say genital tubercle. Genital tubercle.
Genital tubercle. Okay.
So you can see that the erectile bodies are surrounded by a tissue that we call the tunica albuginea. So tunica albuginea, then directly external to it is the bulk fascia. This is it, bulk fascia. Now it's important to appreciate that the bulk fascia surrounds the dorsal nerve, the dorsal artery, and especially the dorsal vein. This dorsal vein. So what they do is that when there's erection and there's squeezing of this bulk fascia, it will squeeze this deep dorsal vein. It will squeeze that deep dorsal vein and it will prevent blood from draining out the deep dorsal vein. So blood will become, how do I put it, retained within that penile tissue so that it can become engorged. This is tightening of the bulk fascia. Then what is external to the bulk fascia, which is a deep fascia, is a superficial fascia that we call the dartos muscle or the dartos fascia. Then the most external one is the skin. So from outward to inward, you have the skin, you have the superficial fascia. The superficial fascia folds together to form a muscle that we call the dartos muscle. Then after the superficial fascia, you have a connective tissue. Then you now have the deep fascia that is next to it, which is the bulk fascia. Then you have the tunica albuginea that invests on all the erectile structures. What are the two erectile structures? Your true corpus cavernosum, that becomes rigid, and the one that surrounds it, which is the corpus spongiosum. I think it's clear to everyone now.
Babawale,
Yes,
the erectile tissue for males is the corpus cavernosum and corpus spongiosum, right?
yes, yes. For
So the
female,
two of them. So the ones that get engorged, because I've seen this question before. The one that gets engorged is
yes.
the corpus cavernosum, right?
Fantastic, fantastic. Corpus cavernosum
Okay.
will get engorged so that erection can
Can occur.
yes.
Okay.
So it's actually your
Okay.
corpus
Then
cavernosum.
the spongiosum will occlude the urethra, abi? Or
Yeah.
how does that one work?
So it has to relax so that the urethra,
Okay.
will be able to allow semen to pass through. You have achieved erection
Pass
so
through
that,
after
you know,
that's at the point of emission,
you
right?
get it, you get it. So you have achieved your
All right.
erection.
All right.
Everything gets rigid when you want to achieve erection. So once you have introduced, the penis to now,
Mm-hmm.
achieve the process of emission so that the semen can move outward. Your spongiosum has to relax
Yeah.
so that your urethra can dilate and semen will pass through.
Okay. Okay. Then
Mhm.
it is the vestibular bulb, right?
Exactly. It is the vestibular bud that
All right.
gets erected
Thank you.
in females.
Okay.
All right.
Okay.
So
Thank you.
guys, we are done. Next time we'll just continue from trauma and we'll quickly move.